Greetings, everyone. As you filter in, we will get started in just 1 minute. All right, it's 3:01, so let's get this party started. Greetings and welcome. My name is Toby Brooks. I'm serving as one of the co-chairs for the program today. It's my distinct pleasure to get a chance to introduce today's session, as well as some of the things we have for you in the rest of the day and tomorrow. First of all, I want to send out a big note of thanks to the planning committee. Their bios are located in your agenda packet. Hannah, I believe she's already put that link in the chat, so feel free to click on that and check out the bios for all those who really worked extra hard. Honestly, I've been a part of several of efforts like this, and this is probably the hardest working team. And a special shout out to Patricia, who is she's a saint. She if I ever need someone to herd cats, she is an expert. She managed to get us on track and keep us on track, and a special thanks. And then also Hannah Goodtree also did a fantastic job. So thank you to them. Really, today's session got its start back in 2021. I was fortunate enough to be invited to participate in the closing session of the Lessons Learned in Health Professions Education from the COVID-19 pandemic. And that's when we started talking about implementation science. And implementation science isn't new. The title maybe is newer, but it is certainly a concept that has been around for ages. And in medicine and healthcare, we've long claimed that we want to be about the evidence. Gone are the days when we do things that our predecessors did just because our predecessors did them. We want the evidence to show. And so during that closing session, we felt like it really struck a nerve. People got excited about this idea of, if we can apply evidence in our clinical practice, why can't we apply evidence in our teaching practice? And the short answer is we can't. And even maybe the more ethical answer is we should. And so today's session and tomorrow's efforts are going to kind of take you down this path. And I will warn you, once you start to open this box, your teaching practice is never going to be the same. And so that may be a little terrifying, but more than that, it should be exciting. And so joining me today is my partner in crime from around the world, around the globe, Nazreen Jassani, who's at the Center for Evidence-Based Healthcare at Stellenbosch University. So at this time, I'll hand it over to Nazreen.
Thanks, Toby, and a warm welcome again to all of you. I know it's close to the end of the day for you all, but given that it's 10 p.m. for me here in South Africa, I'm inspired to pull through if you are. I am heartened to see so many of you from across the health professions attending this workshop. Clearly, it's a topic of interest for us all. And I hope that by the end of the workshop, as Toby said, you come away feeling inspired and empowered to incorporate implementation science into your teaching and facilitation. We realize that each one of you attending this workshop is at a different level of use and understanding of what implementation science is and how to apply it. And we know this because we too, the planning committee, are at different levels of use and understanding. And as we were planning this workshop, it became crystal clear that while some educators have been using implementation science in developing and improving their pedagogy or andragogy, it's not as widely integrated in health professions education. So that's kind of what made planning the workshop a bit of a challenge. We grappled with terminologies from different disciplines. We debated focusing on implementation science versus implementation research. And we searched for examples from which to draw inspiration. We hope that what we eventually landed on will be 2 days of opportunity to learn from those who do implementation science, and for all of us to consider how we might use it to improve health professions education, both in the classroom as well as in the clinic. So without further ado, I'd like to kick off the session with a poll on where we're all at with respect to our implementation science knowledge. So if I could ask Hannah to kindly display the anonymous poll and ask you all to submit your respective answers, that would be great. It'll only take a few seconds. Thanks, Hannah. Okay. I get a sense that perhaps everyone has cast their vote. Hannah, do you think it's safe to close and share the results? Aha, where are we at? Okay, so looks like the majority, but not by a long shot. Implementation science is new to me. And then on the other spectrum, we've got I use implementation science and health professions education. So that's kind of fantastic because I think we can get to learn from across the board for those that for those for whom it's new. And I promise you, by the end of the 2 days, you might have this moment where you're like, I actually knew about it, but I didn't know it was called implementation science, and I'm already using it. That happens a lot. And then we've got those somewhere in the middle. And so I think this is going to be really, really helpful in the next 2 days. Thanks, Hannah. And thanks everyone for your honest responses. I think the person who will really be able to use that poll result is Dr. Rachel Switcher, who you met in the pre-workshop session and who will tailor her introduction to meet your needs based on the poll results. Dr. Rachel Switcher is an instructor in the School of Psychological Science at Oregon State University. Her PhD dissertation is perfect for this workshop. It looked at implementation science in teaching and learning in higher education. So she now does this interdisciplinary research focusing on applying an implementation science lens to the translation of cognitive psychology to promote evidence-based teaching in higher education. So very, very relevant to our group here. And so without further ado, Rachel, I'll hand over to you. Thank you.
Okay, great. Thank you so much, Nazreen, for that lovely introduction. Hello to everybody in the room and hello to everybody on Zoom. It is such an honor for me to be here today to talk with you about using implementation science in health profession education. As Nazreen mentioned, my own interest is in applying cognitive psychology to teaching and learning, but I'm very excited for the chance to sort of cross some silos in higher education, if you will. Next slide. So I am here in person in Washington, DC. And so I wanted to take a minute just to acknowledge what we are doing here is based on sort of a legacy. So this land here in Washington, DC is most closely associated with the Nacotchtank and Piscataway people. Piscataway history tells us that their stewardship of this land extends back for at least 24,000 years. The Piscataway Conoy people are modern people still living on and taking care of this land today. I want us to acknowledge the privilege of living and doing business here today exists because of oppression, genocide, and removal of the original caretakers of these lands and resources. I hope to use this land acknowledgement as a way to uplift the current efforts of the Cedarville Band of Piscataway Conoy Indians to their mission of restoring sovereignty and returning to their rightful place on this land. If anybody's interested in where I came up with this idea at, it's not my own, much like most of my ideas that I'll share with you here today. And there are links available in the presentation if you're interested in using your own land acknowledgement in the future. Next slide. So in my first 20 minutes here, which is not that long of a time, I'm going to both review implementation science and talk to you about evidence-based teaching practices that are a result of a literature review I conducted in preparation for this meeting that are regularly used in health professions education. Next slide. All right, so what is implementation science? I did notice that most of you in the poll, and hopefully those of you here, said you know something about implementation science. If not, you're already using it and already using it in the ways that we're going to talk about today, which is awesome. Also, if you're feeling like you'd like a little bit more meat than what I'm about to give you, I invite you to watch the webinar that was pre-recorded for today's session. Next slide. So here's the official definition of implementation science. This might seem familiar to you from that pre-recorded webinar. And Eccles and Mittman defined implementation science as the scientific study of methods to promote uptake of research findings in real-world practice settings to improve quality of care. And that bit about quality of care comes from the fact that implementation science was developed out of medicine and public health and behavioral health fields to bridge the gap between research and practice. In plain language, next, what we're talking about here today is the thing. And the thing is going to be some teaching practice, a pedagogical practice or an andragogical practice, if you will, is the thing. Next. Implementation strategies are the ways that we do the thing. How do we actually get people in places to use that particular practice that we're interested in? Next. And implementation outcomes are a measure of how well those people or those institutions are doing the thing. And so it's a little bit of a mindset shift from the more traditional type of research that we might be used to, which tends to be effectiveness of a particular innovation, right? We want to know, does it work? Does it improve patient outcomes? Does it improve student outcomes? And implementation science basically takes one more step further in asking research questions than we might be used to. Next slide. Implementation studies at the top of this chart is not just asking whether a program works, but it's asking what makes the program work. And what makes the program work, it turns out, is a huge question with many variables. And implementation science was created and has been refined and continues to be refined in order to decide what are the most important factors we should be looking at when we're trying to determine whether or not a particular practice works. What I also want you to sort of take away from this slide is that implementation studies tend to be conducted on the assumption that you know a thing works. Our evidence-based practice actually has evidence, right, in indicating that it's useful. And when we're talking about a teaching context for that, does a particular pedagogical practice improve what our students are learning or what our students are doing, either in the classroom or after they've graduated and come to work in the field? But what a lot of implementation scientists argue is that even if you're starting way down at this pre-innovation phase, you can consider implementation outcomes so that you can design your research as you go to measure bits and pieces of that implementation so that by the time you get to the end, you're already informed about some of those pieces. And I think that's probably what will sort of revolve around in our work over the next 2 days. And you'll see what I mean by that in just a minute. Next slide. All right, so I've adapted, this is an image from Proctor and colleagues from 2011 that outlines implementation outcomes specifically in the context of a clinical institution and then patients who are receiving care in that institution. And instead, what I've done here is changed it to help us think about implementation science in a pedagogical context. So the implementation outcomes are the same as Proctor and her colleagues proposed. So acceptability refers to how well the particular practice is sort of approved, if you will, by the students who are the recipients of that pedagogical practice. It also refers to whether or not faculty using the practice think it's acceptable. Are they satisfied with it? Adoption refers to the rate of uptake. Appropriateness is, does this particular practice fit the context? What's the cost of using it? Feasibility is, how easy is it to use? Fidelity is, are people using it as we intend them to be? This is maybe the most difficult thing to ensure when we talk about innovations of any kind, because what we know is that most people want to modify something about a practice to make it fit the context. And what we don't usually know, that would be fine, right? We all want something we can personalize a little bit. I don't like teaching the way other people tell me either, right? But the question we don't normally have the answer to, though, is what are the components of that practice that are absolutely critical for it to be effective? And then everything else can be adapted. But we don't typically have the answer to that question. Spread refers to sort of how deep in the community is the practice uptaken. And then sustainability is, you know, when we're done doing our research project, is this a practice that you'll continue using? And we know that measuring these implementation outcomes is related to what we hope our students are doing in the classroom. So typical effectiveness research focuses on the knowledge our students are gaining, or it focuses on their self-efficacy. Do they feel confident and capable of delivering care after they've learned about a particular thing? Are they motivated either to engage with the practice or to engage in the class to improve their own learning? And then the number of times I came across critical thinking, problem solving, and decision making in the literature was just astounding. I mean, in psychology, we also think our students should be critical thinkers, but it came to my awareness that, like, oh man, you really want that in the people that are providing you your healthcare. And so decision making and problem solving all include critical thinking skills that we hope our students are learning. And then we know that, you know, or we approach our teaching assuming that what we do with our students in the classroom will affect patients. Will it affect patient safety? There's a lot of in the literature about that. Does it improve the care that students take once they're out in that clinical practice? Does it help to have patients treated more equitably by their caretakers or their caregivers? Is that care patient-centered? Is it timely? Is it efficient? All of these things we consider clinical outcomes. These are also outlined in the 2006 Institute of Medicine Standards of Care. And they are not directly the outcomes that we're interested in implementation science, but we think with the implementation of a particular practice that there will be this downward sort of spread of knowledge that will then improve these clinical outcomes for patients. All right, next slide. There we go. So what I recently suggested to some of my psychology colleagues at a conference was just dip the bare tippy top of your toe into implementation science. I will say, maybe this is like too much information for you all, but when I wanted to learn implementation science, I had to teach it to myself. So I didn't have anybody at my institution doing implementation science, certainly not in psychology, not in education. There was one person that I took an implementation science class from at my university, but she taught it at a level that like I had already built up my knowledge about it. And this isn't to pat myself on the back, but just to say I've attended conferences, I have attended talks. I've done years in the making of trying to digest this information to give it to other people in an easy to understand way. So yeah, so just your tippy toes into the implementation science waters. And two ways we can do that is, one, improve the transparency of our reporting. So we talk a lot about this just in our evidence base in general. When you're doing research, it's so difficult to replicate other people's research because you don't have the details you need to do so, right? And the Russell Blasco was actually the first person I ever saw to talk about implementation science. He did a talk at OSU when I was there. And that just inspired, I don't know, it inspired me. I've never met him. I've never had the chance to tell him he inspires me. So if any of you know him, please pass that along. But he modified the medical consort guidelines for reporting to include elements of implementation. And so if we could all try to make a consort sort of diagram of the research that we're doing, and get that published, that's a step in the right direction, because it's really transparency at a level that we need. And then also to begin evaluating the implementation process. So when you're using a practice in your classroom, just collect some data about, oh, I don't know, do students like the practice? Do students engage with the practice? Was it easy for yourself to use in the classroom, or do you need to ditch it and try something else? And it's most likely the case that you're already doing this in some way. So there, 100% of you, 30% of you said you use implementation science in HP, and now 100% of you are saying like, oh yeah, I do that. So we're done. No, I'm just kidding. Yeah, question.
Eric has said that the Squire EDU guidelines are also helpful. Are you aware of those? Squire.
I'll write it down. No, thank you.
Just real quickly, they came out of the quality improvement world, and so they were designed on how to report educational intervention. So not unlike Consort, but if for those working in education, it's another nice kind of checklist when you're thinking about reporting and stuff. So I threw it in as another resource in case it's helpful.
Thank you. I really appreciate that. Part of my agreeing to do this was also so I could learn from other people. So I get pretty excited when people have things to contribute like this. Okay, let's see, checking on time. All right, so let me review a little bit for you. Next slide, please. What types of teaching practices have a pretty solid evidence base in specifically health professions education? Next slide. To get us started, what we want to think about is a couple people have forayed into applying the science of learning to health professions education. And from this work, we can see that things that come from the science of learning that apply to health professions education are things like understanding information processing. So for example, how to create multimedia presentations or videos, instructional videos, that don't surpass the cognitive load threshold of our students. How do we make them simple enough to understand, but not too complex that the students can't get it? Retrieval practice, being able to not just recall information because you have a test on it, but actually using that retrieval as a learning tool. So trying again and again with something like self-quizzing, for example, or using quizzes that are based in an online textbook. Simulation and case-based studies, we're going to talk a lot about, especially tomorrow. Reflection happens in a lot of ways, but in general, reflecting on your own learning or metacognition, right? Thinking about your own thinking is shown to improve student outcomes. And also thinking about the social context in which learning occurs. Because a lot of times we think, oh, it's just this one individual student that's having trouble. What sort of deficit do they have that I can fix? And that's probably putting it a little bit harshly. I don't think we think in those terms about our students, but we approach teaching that way a lot of times. And what most is likely is the case is it's a combination of some personal characteristics, but also the actual classroom environment that our students are learning in. And that's sometimes referred to also as situated learning. There's another paper from 2010, next, about education strategies specifically for developing clinical reasoning skills. And some of those things are problem-based learning, an integrative curriculum, reflection, and concept mapping. And so what I did was I started with these two papers and I sort of went on a little scavenger hunt about, well, what do we know about teaching practices specifically in HPE that are evidence-based? And here's a short list that I came up with next. And it is not by any means all-inclusive. So this isn't me telling you there are only these three things and just if you use these, you'll be fine. That's not my recommendation. But I chose these three because I did find research on them. Next. And you'll note in the slide, I've put a caveat, which is that every single review and meta-analysis I came by basically concluded that we still don't know. We still don't know how to do flipped learning. Raise your hand if that's happened to you. That's happened to me. I cried one day in class. My students are, we hate flipped learning. I'll be right back. That's not even a lie. I wish that was a lie. I think I might have said this on one of our early planning meetings, but the key to flipped learning is to never tell anybody it's flipped. Yeah, there's a lot of preconceived notions about what that means and students don't respond to it well. But despite sort of a lack of evidence for these practices, I'm just going to go really quickly through a synopsis of each one. Next slide, please. So the first is flipped learning. Next. And here's a definition for you. Don't read that. It's fine. Whatever you think flipped learning is, that's what it is. Okay, it doesn't matter. You can go back to this later. But basically, the idea is that you take what normally would be group learning lecture, and you move it to an asynchronous space where students can do it at their own pace. And there are many different ways that you can do that. Next. So what do we know about the effectiveness of flipped learning? So there's some evidence to suggest that it promotes student engagement. That's great. I mean, I would hope so. So if you've tried flipped learning or you know anything about it, the entire point is that your class time together is spent in active learning. So working on a problem or being in small groups for discussion. So if we're not promoting student engagement with that model of teaching, we're probably, that's like the bare minimum evidence, right? Oh, and sorry, I just realized there's a typo here, but it improves student performance and then also clinical outcomes. So that's exciting. We have that evidence from nursing. We also have some evidence from pharmacy that a flipped classroom can increase course, quiz, and final exam grades. That seems pretty good if we all assume we're good exam writers and that exams assess learning. Sorry, I'm gonna have some coffee so I'm being sassy. And then there's also some evidence to suggest that students tend to prefer this in-class focus on hands-on learning. That's not a surprise. You all are sitting here listening to me thinking like, yeah, I wish we'd do something besides this, right? Okay, so next. Oh, I don't know why these, sorry, I changed all the links to black before I sent the PowerPoint, so I'm really sorry. But we do have some design principles published about how to create a flipped classroom and also recommendations for implementing a flipped classroom. And if we have time later, I can show those to you. They're in the PowerPoint presentation, or you can refer back to them yourself. Next. But then we're left with all of these questions about implementing. So how do we operationalize pre and in-class activities? What type of content will that work for versus what type of content is that not a good fit for? How are students prepared? So what do we tell students about a flipped classroom? Remember, we don't tell them it's a flipped classroom. What makes faculty maybe hesitant to adopt this practice? It turns out I saw cited in one of the sources that it took some nursing faculty 127% of the time it would take them normally to prepare for class. Seems like a good reason not to do it. I don't know how well you all pay your faculty, but I don't want to work an extra that much for the money that I'm making. How do we know how class size affects flipped learning? What are the aspects of flipped learning that have to be maintained versus what are those that are adaptable? All right, so really quick summary. Next is problem-based learning. Next. Nope. No, you're fine, sorry. So the definition of problem-based learning. I left it blank on the slide, which is why I'm not having Hannah put it back up there. Is there an agreed upon definition of problem-based learning? Maybe. So raise your hand if you think you know what problem-based learning is. Like you know what it is, you've used it before. Okay, then you know what problem-based learning is. There's an emphasis on a real world scenario that students are working on together to problem solve, right? To think critically about. There's some suggestions in the literature that, for example, these problems be open-ended, meaning there's no one correct answer, so that students are free to think about them any way they want to, or like in the way that makes most sense to them. In terms of evidence for effectiveness, we see an increase in self-directed study skills and also recall of information. And what's really impressive is that at least in some research, we see transfer of that knowledge, which is always what we're really hoping for, right? Like, not can you just remember it here, but when you get out into a clinical rotation or an internship, are you still able to recall that information and use it? We see greater motivation for attending class. That's always good. Satisfaction with the course for both students and faculty. So faculty enjoy teaching this way. It feels real, right? We're all there because we want to connect with our students and have meaningful interactions with them. And so that's great that faculty are feeling also invigorated by this. And then also better clinical knowledge and skills. And so from the literature, we have a few best practices. So next. And those are best practices for the problem-based learning process. And that's a 5-step process. So the facilitator presents a realistic clinical situation to a small group of students. The students discuss the problem, relate it to their prior knowledge or experience, and identify learning goals. The facilitator guides critical analysis of the case. Students seek out additional resources to help with the case. And then these folks actually argue that in a second session, students come back to present their new information and a potential solution to the problem. So you can read more about that in the citation I provided. Best practices are also to think about the constructive, collaborative, contextual, and self-directed nature of the learning that's occurring. So how do we literally construct the solution to the problem in a collaborative way? What about the contextual information from the case that we've been giving is helpful? And how does that motivate self-directed learning as opposed to just receiving that knowledge sort of passively? Problems should be complex and open-ended. I already mentioned this. And the real emphasis in problem-based learning is on the instructor as a facilitator, not an expert. Okay, so what I mean by that is rather than transmitting information from the instructor to the students, the facilitator or the instructor asks a lot of questions so that students can do that critical thinking on their own. All right, next. So we still have some questions about implementation. Again, we see this question about why might educators not want to adopt problem-based learning? The most common answer to this that I found in the literature so far is that it requires a high level of self-efficacy as a facilitator. And I don't know how it is for you all, but in I've been in multiple graduate programs. Nobody teaches you how to teach. Everybody teaches you how to do your topical research, right? But we're not typically trained purposefully in things like how to facilitate problem-based learning, okay? So really what I found is the answer to this first question is educators are hesitant because of low self-efficacy. They don't feel confident in their ability to do so. So should problem-based learning be used as one of many teaching methods, or should it be integrated into the curriculum, meaning that all of the courses the students would take have some aspect of problem-based learning? There's pros and cons to both of those. What do educators need to feel comfortable with PBL? What is the specific role of the facilitator, and how do students perceive problem-based learning? So again, just a sample of the potential questions we might ask ourselves. And I am over time, so we can skip to the roundtable discussion slide. I had one more in there about reflection, which you're welcome to review as you'd like for some sources of information. But I think next what we're going to do is invite some collaborators to a roundtable discussion to speak about their own experiences with using implementation science in health professions education. Yeah, you can end it. All right. Okay, so here today for this reflection session are Natalie Douglas, who's a professor in communication sciences and disorders at Central Michigan University. Give a little wave. Hannah Wilson in nutrition, dietetics, and exercise science at Concordia College, which is in Minnesota. And Gail Jensen, Vice Provost for Learning and Assessment and a Professor of Physical Therapy in the School of Pharmacy and Health Professions for Creighton University. So without further ado, we'll just ask you to reflect on what you've heard about implementation science and what you think about using it in health professions education. And whoever wants to go first, I think you could just unmute.
Well, I'll jump in.
Thank you, Gail.
And my friends are, a few of my friends are there, and I may go off script here a little bit. I really appreciate Rachel's setting the stage here. And one thing that I'm very much committed to education research and how important the learning sciences are in what we do in education research. So I think one of our challenges too, yes, the implementation science structure, but we also have to help our educators understand at this deeper level the conceptual understanding of the learning sciences and how to put that into practice. And I think Rachel laid out some ideas there, because what we're trying to do is prepare an expert learner, not just dump knowledge into their head. You know, we spend far too much time on content knowledge, procedural knowledge, but it's that deeper understanding and the cognitive knowledge structure, clinical knowledge structure, where we're trying to get the learner. And that's not easy. But we also know learning is really messy because, you know, one of my mentors, Lee Shulman, was fond of saying it's the particular and it's the general. So what happens in your classroom? Teaching's like dry ice. It evaporates, right? So how do you problematize it? And then what's general about it? How does theory apply to that and help us in moving evidence forward? And it's not just cognition, it's culture and context. So I can stop there. I got more to say, but I don't want to dominate here. And it's 100 degrees here in Nebraska. Oh my God, it's awful.
Thanks, Gail, and thank you, Rachel. This has been such an inspiring conversation, and it's wonderful to see all of this interest in implementation science and the crossover with health professions education. It's just really exciting, and I'm so happy to be here. So one of the things, and this really goes along with what Gail just said and a lot of what Rachel presented as well, is as a health professions educator, what implementation science I think brings to me is the importance of the organizational context. So I think so often in the classroom, we are thinking about ways that we can convey, this is how you do XYZ evidence-based practice. And then our students go away on internship and they come back and they say, well, I can't do that, and I think many times we're so focused at that level of the individual and trying to make that individual change. And that's important and that's a piece of it. But I think especially in health professions, there's also the organizational context and thinking about how we can prepare our students to be cognizant not just of their individual behavior, but the behavior of the organization and what's necessary to think about how organizational context and climate also drive evidence-based practice in healthcare. And it's one of those situations that is so messy and there's so much that we're learning, but I think it also can really provide more of, this is what it's really going to be like when you're out there in the real world. And it can provide, I think, a helpful framework for that.
Thank you, Natalie.
Yeah, thanks, Natalie. So when I think about like pulling back, how do we actually do implementation science in health professions education? I think one of the biggest barriers is the data collection piece. What does that look like from a researcher perspective? So when we were planning for this roundtable, we were talking about how most of you will probably find at the end of this workshop that you're doing something that would technically count as implementation science. So even if you're already doing a final course eval, which I'm sure everybody does, you could pretty easily tack on a validated survey to assess acceptability of some teaching strategy that Rachel has talked about. If you just have like casual discussions with your students when you try something new in the classroom, you could I don't want to say easily, but relatively easily turn that into some type of focus group or something like that. So there's a lot of things that you are probably already doing that can kind of help you get over that at least mental barrier of figuring out, I don't think I have enough time to do this, when you might not actually already be doing it. So.
Absolutely. And to go along with that, I just wanted to throw in the chat just an example of an acceptability, feasibility measure. It's only 12 items. It's really 4 items for acceptability, 4 for appropriateness, and 4 for feasibility. So this is a validated measure and it's really simple. I can put the paper that goes along with it in the chat as well, just to, again, go along with what Hannah was saying in terms of this doesn't necessarily have to be a rehaul of everything, right? But it's picking one practice and thinking about ways to collect some of that data along what you're likely already doing in some way.
Natalie, I'm just curious, is that the Weiner 2017 measure?
Yes.
Yeah. So in my own, just to provide an example to folks, in my own research, I had intro psych students complete a particular assignment that contained an intervention. And once they completed that assignment, it was just put in the LMS as a normal assignment. We use Canvas. And then once they submitted that, there were survey questions, basically, that were each of these items that Natalie mentioned. So the students filled those out. They just completed the assignment. They answered those 12 questions related to the assignment. And those are the data that I used for students' perceptions of the intervention. Super easy.
I think the other thing that implementation science structure offers us is the ability to collaborate across classrooms, across institutions. And, education research, we're used to having bake sales to get money, right? I mean, we do this kind of one shot, we're criticized, our methods are soft, you're not real researchers. But if we share methods and we share a structure, that provides us, I think, with the ability to really go after some of these very important learning issues, which we all share, the learning issues. So, and it goes after what Rachel's, we teach the way we're taught unless we've had some kind of pedagogical intervention, some kind of teaching intervention. And the Carnegie Foundation, they were very critical of doctoral education a few years ago and said, you know what, PhDs need to learn how to teach. So.
And something you just said, Gail, about sort of the perception of educational research. I think implementation science provides us with a terminology, a structure, a framework for systematically measuring the variables that we're already really interested in knowing more about. And that's, I think, what I found so interesting about it was because I had all these questions in mind about my students and my classroom context, and implementation science gave me a vocabulary to work with that was already well respected by entire fields of people. That was even something I had to tell my dissertation committee about. Like, yeah, there's funding from NIH for this. I didn't make this up.
I think that's such a great point. You know, and with implementation science, mixed methods are already accepted, right? So it's not having to spend, you know, 15 pages in a manuscript justifying qualitative methods, right? Because it's understood that if you want understanding of human behavior change, right, that you have to go deep, you have to have those mixed methods. So I agree with Rachel with what you're saying. It really provides a structure, the vocabulary to be able to really focus more on the work and maybe less on having to justify it, you know, because that vocabulary is there.
And I think we found in the planning of this workshop that so few people are doing implementation science in education research. Anything that you can do would be helpful in expanding the literature and helping other educators. So don't be afraid to do something. Dip your toes in, like Rachel said.
You know, I think the other opportunity we have is to be a commuter across our disciplines. So not only across the health professions, but bringing in folks like Rachel. We've got somebody from our psychology department involved in a study we're doing on empathy with the medical students. So it's been very, very helpful.
I know I'm very biased, but I think psychologists have a lot to offer educators.
Yeah, there is a question in the chat box. Do you need IRB approval to use student evaluation data in
sure do.
publications?
Yeah, that's a great question. So at our institution, yes, even if we can get our IRB protocols considered under the new FLEX regulation, which is I don't know if this is the actual distinction between it and other types of review, but it's like the easiest kind. We have to indicate in our consent forms to students that we will be using their data for publication. And then we need their consent to do that in order to use it for publication. So my general answer is yes. And my caveat answer is how you do that will depend in part on your IRB.
There's another question.
Sure, yeah, please.
Are there funding opportunities for non-US based investigators? I guess you mentioned NIH. Are there things outside of this country?
Oh, sure. So I should mention specifically that NIH funds medical related implementation science, not education related implementation science. To date, the only thing I've been successful getting grant money for is a small early career researcher grant for my classroom-based implementation research. I don't know of any formal funding mechanisms, even in the US, that support this kind of research, which kind of touches back to what Gail mentioned. I don't know, do any of the discussants know specifically of funding opportunities?
The majority of funding opportunities I know of are really tend to be US centric or Australian or UK in the National Health Service. And sometimes it might be referred to as improvement science or knowledge translation, or have maybe a different terminology for something very similar. One thing that I put in the chat is the link to the Global Implementation Society. And they really, I'm not sure about funding, but I do know that they have a real focus on engaging other countries that are less Eurocentric, less United States centric. So it might be a place to start in terms of developing some of those connections outside of the US.
I will also say, not related to funding, but just related to sort of a great informational resource. If you are able to join the Society for Implementation Research Collaboration, which the acronym is SIRC, S-I-R-C, they have a members only assessment database, and it is incredible. So it takes every one of those implementation outcomes I've shown you already, provides citations for measures that are in the process of being validated, and tells you about their psychometric properties, so reliability and validity. And their annual meetings in San Diego this year, in case anybody lives in Southern California. All right, did we have any other sort of last thoughts from the panel?
I would just advocate the importance of faculty development. I'd say that about almost everything, but I think if we want to promote change, the need to develop faculty and understanding the structures and the opportunities is really, really important. I mean, if we don't have evidence of learning, we don't have evidence of teaching. And then the connection, you talked about the situated learning. We know the connection to the clinical side is what makes learning stick. It's very important for us in the health professions.
Just one comment before we move on. I really appreciated one of the earlier slides that was, if you already have your evidence base, then you can study how to implement it. I think in health professions education, we're often in the early stages where we're not convinced that there's one best practice and one thing that we want to study in different spaces. We're still in the deciding if our intervention is effective. So I really liked that you had suggested that we can apply the implementation science at the earliest stages of examining things. And I think that's where we have an opportunity, because we do it differently. But if we apply the rigor of implementation science early on, then I think, to your point, Gail, we can work across our disciplines and we can build the rigor. I've used implementation science in work that sort of straddles health workforce broadly, looking at how the impact is on health workforce training, but as it applies to health outcomes. And I think that, I just think there's a lot of opportunity for us to use this rigor in our work. And I think that the question that Patricia, somebody must have asked about IRB, I think students are human subjects. So if we're going to use their data, evaluation data, or whatever they are, anything that uses a human subject, I think should go through an IRB review, because that kind of clarifies that. But I think there's a lot of opportunity for us across disciplines here.
Thank you.
In the chat, and then a hand out in the Zoom land. The chat question is, clinical and translation science institutes have the ability to fund implementation projects, yes or no?
So sorry, I'm also reading the chat from over here, and I think that both of the comments in the chat are sort of, well, I don't know the answer to the first one. And then the information that AHRQ is funding some implementation is great information for us to have, so we can look into that.
And there's a hand up by Sue Ravenna.
Yes. Yes. Hi,
Yeah,
thank
ahead,
you.
Sue.
Hi. I'm just curious, do you feel that there's any relevance for this in clinical rotations as well, or just more within the didactic content of our programs?
So without trying at all to sound flippant, I think there's space for implementation science everywhere. Specifically though, in clinical training, I think the organizational context, like Natalie really talked about, is so important and has such a bearing on how students learn. It seems to me, being outside health professions education, so take this with a grain of salt, but it seems to me recording that contextual information while students are out on internship and then seeing that information when they come back to the classroom would be very illustrative and maybe even worthwhile to talk with students about their different experiences and what about those organizations promoted or hindered learning. So I do see a place for it there.
Thank you.
Yeah, you're welcome.
Rich, what do you think that'd be a good place for the CFIR? Because it really talks about inner and outer conditions, and I think that's a big part of clinical training is the context.
Yeah,
That's
absolutely.
particularly why I like that framework.
Same, yeah. I think the consolidated framework for implementation research is sort of the most comprehensive list of questions you could have about what to consider for implementation. And something that I like about that framework also is the authors are very explicit that you should not try to measure all of those things at one time, that you should select the questions that seem most relevant to the implementation in your local context as possible.
Toby Brooks has a comment about IRB. I don't know if you want to respond or just acknowledge it.
I can't see it. Sorry.
Well, maybe ask him to.
Okay.
I'm muted, so ask him to.
Toby, what were you saying about the IRB?
No, I was just saying as this type of work becomes less novel and as IRBs become more familiar with it, I think we'll see maybe less tendency. Like the very first project I did, they went ahead and sent it to full review. And part of it was because we had a couple of students who were under the age of 18 and a freshman undergrad class. But particularly at our health sciences center, they're used to doing, full scale investigations with patients and such, and education research hasn't been real common. So it's not something they see very frequently as of right now, but hopefully in the future, as our work continues, they'll have a little bit less heartburn with doing this type of thing.
Yeah, thank you for that. Yeah.
Anna Wilson?
I was just responding to that question a while back about clinical and translational science institutes. I'm most familiar with in the state of Georgia, but I know in Georgia, they typically had a high value placed on implementation science because of in their title, they're interested in translation of research. So that could definitely be something to look into.
Here's a question, Rachel, about I wonder if there are ways to find a list of published studies that implemented these implementation science principles, or a reading list for our students or research labs.
I would love to give you a reading list. Yes. Yes, I can do that.
Darla?
So I'm cheating. I raised my hand.
Oh, okay. I did see you. I'm very
I'm sitting
very
in this room,
sorry.
and I thought maybe I can get somebody's attention. So I'm wondering, and this is just for anybody here, if there's a way for us to conceptually bridge the conversation about implementation science and creating inclusive learning environments. Because that was a conversation that we were having earlier about creating an environment that really values different voices, different learning styles, those kinds of things. So I'm just wondering if you've got some thoughts about that.
Do I have thoughts?
I thought so.
Yeah, thank you for that question. So how can we see inclusive teaching and learning as part of what we're doing with implementation science? The thing that comes to mind for me first is that most of the evidence-based practices that I'm suggesting make room for inclusive teaching. So they, by nature, already incorporate best practices for making learning inclusive. So for example, as a flipped classroom moves some instructional materials to online and it's available self-paced, then folks who can't or don't or won't learn well through lecture in a classroom are being given the opportunity to learn that material in a different way. So some of these principles increase accessibility. Some of these methods might decrease accessibility. So we're going to talk in a little bit about simulation-based education. And I thought to myself the whole time I was researching it, but what if you need this to be accessible? What would that look like? And then in terms of hearing from folks, from voices we don't typically hear from, things like active class discussions and problem-based learning are really a great forum for inviting people to speak. And I think that comes back to the issue we've sort of been going around and around with, and which Gail really highlighted, which is faculty development. So if you have an instructor who's trained in inclusive teaching, facilitating problem-based learning, you're likely to get better inclusion of underrepresented students than if you have somebody who's trying it for the first time with no training.
Natalie, would you like to expand on your comment about Dr. Anna Bowman's work?
Sure. She's someone that comes up for me in terms when we were thinking about equity and implementation science. She's published some really great work. I put a little editorial that we did in the chat, but I wonder if some of these conversations about equity and implementation science very well might fit into some of these classroom discussions as well. So I think that's such an interesting direction to think about.
I have a question about your examples on PBL. I noted that the references were really old. And is that because there's nothing new out there or nothing new related to health sciences education? Is that, was there a big review or summary or?
Yeah, so that's a great question. Most of the material I came across that was newer is about specific facets of different types of practices. So PBL, flipped classroom, that sort of thing. And what I did for this presentation was leave those out of the presentations so that I could give more of a summary review. And I wasn't sure where to work it in, but I actually think quite a few of them would fall under the purview of implementation science. So maybe I can put something together before tomorrow's session to show what I mean about that. Because I do think some of the newer work is focusing on determinants or elements of the CFER model that we could use as implementation evidence.
Just really quickly, we're getting some feedback that it would be nice if you guys could just lean forward a little bit, speak a little bit louder so everyone who's not on Zoom can hear you. Thank you.
To the PBL question, it'll be interesting to see. I know, our medical school is using team-based learning, but the emphasis now on the master adaptive learner, adaptive expertise, preparing an expert learner, how we understand that and what we do to think that we're actually facilitating that is pretty much shared, I think, a shared conversation across the health professions. We're all talking about competency-based education and how we're going to assess. So
I do think there's a tendency as well in education, and this is for K-12 and for higher education, to be sort of innovation chasers, right? Nobody gets famous by continuing the story somebody else started. And so there is oftentimes sort of time limited chunks of, oh, well, now there's all this research about retrieval practice. And then that's all you heard about at conferences was how to do retrieval practice this way and that way and which way is better. And on the one hand, that's great. Maybe now I know how to use retrieval practice in my classroom. I don't. But on the other, what it leads to is sort of this false consensus effect where we think, oh, well, all the research has been done on this now. So we feel secure that it's an evidence-based practice. And that would be great, except that most of that evidence doesn't contain the sort of rich detail we need to use that practice on our own. So really, if you get nothing else out of this presentation, and I actually need to wrap up questions because I have some other things to go over with you today. If you get nothing else, it's just that I'm pleading with you to somewhere publish, whether that's a journal or a white paper or a preprint server to publish the work that you're already doing. Like just write out how you teach a thing and put it on the internet so somebody else can find it. And you wouldn't believe how helpful that can be for other folks. When I published, hopefully the paper you're all familiar with, which is Implementation Science in Higher Education, I actually wasn't sure where to publish it. There aren't any implementation science specific educational journals. And so I put it up on a preprint server. And when I finally decided where to publish it, it's like an invitation only journal. And they said no. And then I wrote back and said, well, does it matter that my preprint has been downloaded over 300 times on a preprint server? And they said, oh, sure, you want to go ahead and send that in? And I said, I sure will. Thank you so much for your consideration. I don't take no as an answer very easily. But, and then, so Sue, you've had your hand up for a while. We'll just, one last question or comment from you, and then we'll move on to prepping for tomorrow.
Oh, thank you very much. So I know that you've talked about the CFR a few times during the conversation and thinking about the context, the environment. Can you speak a little bit to the individual student, recognizing that, again, with individuals, there might be barriers or facilitators that are specific and unique to our individual students, and how you address that?
Yes. So the CFR model that I keep referring to has 5 different domains, and those domains are characteristics of the intervention or the practice, inner setting, which is about probably, so there's some debate over what counts as an inner context, but I think in our situation, it would be the classroom or the department level. That's up for debate. The outer setting, so maybe at the institutional level, what's happening to promote or hinder a particular practice, the actual process of implementation, and then also individual characteristics. And individual characteristics can apply to the students, or it can apply to the educators. Either way, probably both is best. And this is things like, what are students' knowledge and beliefs about the practice that you're using in the classroom? What's their level of self-efficacy in participating in that practice? So maybe students are feeling pretty shy about group discussions, for example. And also identification with the organization. So in this case, if a student feels like they're really a part of a classroom, maybe they're more likely to engage with the practice than if they feel less like their opinion matters or that their input matters. And so the CFR, which we've been talking about, has a domain to include that.
Thank you.
Oh, you're welcome. Thanks for the question. Okay. Thank you, Hannah. So briefly, I'm just going to prepare us for day 2, which is tomorrow. And tomorrow, what you'll all be doing is working in breakout groups or small groups to discuss how you might be able to apply some elements of simulation, of implementation science to simulation-based education or simulated learning. So I've chosen to go with simulation-based education so that I can abbreviate it SBE. Hopefully that's fine for everybody. And so my working definition that I'll be using for simulation-based education is a teaching strategy that complements traditional training with actual patients and enables students and health professionals to learn in ways that eliminate risk to patients. Of course, this is just one definition. So simulation-based education can, instead of working with actual patients, work with some sort of technology. And I know that that's very common across the simulation literature. And part of the reason for that is because of the risk to patients with trainees. In order to avoid that, then there's some sort of technology that takes the place of a real patient. So we'll be using that sort of idea and then using patients or fake patients. I guess we can use interchangeably there. Next. All right, so what do we know about simulation-based education? So it was immediately clear to me when I started my literature search that we know a lot about simulation-based education, actually. I still read a recent review that said we don't know enough about it, but let's just assume we do know. So the most sort of reliable finding is that simulation-based education improves students' psychomotor skills. So it gives students a chance to practice routines of certain care regimens. So for example, performing CPR. So that by the time they go out into a real world context and they need to apply that set of skills, it's sort of rote. They don't need extra practice. It just comes sort of naturally. But there are some other findings that indicate SBE is effective for improving all of these things that you see here on this slide for students: problem solving, critical thinking, clinical reasoning, judgment, clinical confidence, self-efficacy, motivation, and let's not forget that we have these clinical exams to assess simulation-based education, and part of what they're doing there is situational judgment. I will say that in this particular review of the literature, it seems that these particular outcomes are either improved for students or they're no better than teaching as usual. But there was not any evidence that simulation-based education results in negative outcomes for students. And I think that's always something we need to consider before we adopt a teaching practice. I would argue if there's any evidence that it adversely affects our students, that we don't adopt it. But I didn't come across that in my literature search. So I feel pretty comfortable calling simulation-based education an evidence-based practice. And of course, it's recommended by multiple national groups for being, a particular pedagogical practice for health professions education. SBE can be delivered using high or low fidelity simulation. So high fidelity being where the context is most like a clinical setting as possible, and lower fidelity being perhaps, for example, a case study that you review in class. So not as like the actual context. And it also includes, so I mentioned this already, but different modes, including case studies, technology, and also simulated patients are part of this definition. All right, next. Nope. Can you click next and see what happens? Okay, again. Okay, no, go back. Okay, so we have some best practices that come from the International Nursing Association for Clinical Simulation and Learning. The Board of Directors and the Standards Committee put together a list of best practices for using simulation-based education. Next. Pre-briefing refers to any activity that occurs prior to simulation to ensure that simulation learners are prepared for the educational content, and also that they're aware of sort of what are the ground rules for the simulation-based experience. Next. The simulation design. So there are best practices or standards for simulation design. So simulation-based experiences need to be purposefully and intentionally designed, in case that doesn't go without saying, to meet identified objectives and to optimize students' experience such that they can achieve those objectives. Next. There are standards and best practices for facilitation. So facilitation methods are really varied across contexts, but the critical aspect here is that a specific facilitation method is best suited to the learning needs of the learner to reach those expected outcomes or objectives. Next. Debriefing is also an essential component of simulation-based education. This is any process like feedback or guided reflection about the experience. And I found some interesting evidence to suggest that debriefing after the experience is effective, while providing feedback during the experience seems to have no effect on student outcomes. Next. Operations. This has to do with the organizational context that Natalie was talking to us about during the roundtable discussion. So what are the systems and the infrastructure to support and maintain a department's ability to use simulation-based education? Next. We need clear learning objectives for the students. So what are the outcomes that our students should be able to achieve after participating in this simulation-based educational experience? Next. I apologize for that animation. Okay, so we still have questions though about implementation, and these are actually, so I know Kathy called me out for using old citations, but this Issenberg paper from 2011 is amazing, and it lists a research agenda for simulation-based education, and it is almost entirely questions about implementation. So for example, what debriefing mode works best and under what conditions? We probably don't know the answer to that question. How does individual learner motivation affect the knowledge and the skills that are gained from simulation-based activities? How do different characteristics of the environment affect learning in a simulation? And so there are some examples here of what I mean by that. So individual versus group learning, peers versus multidisciplinary. So there's a lot of talk about using simulation-based education in interprofessional teams. Timing, frequency, procedure. So is SBE embedded in one course, or is it embedded in an entire curriculum? There's a lot of evidence to suggest it needs to be integrated throughout the curriculum to be effective. How can institutions make sure that this implementation is sustained and that it evolves over time to meet changing needs of both our learners and the clinical context? And then the last one is just an example here. For example, can small portable systems operated by a small cadre of full-time, well-trained simulation experts lead to effective outcomes? So this idea would be that you'd call in an SBE team to your classroom to facilitate that experience for students, rather than training yourself and being the facilitator of that simulation. And that's just one suggestion about how SBE might operate in and through a curriculum. So obviously there are other options. So we have a lot of questions still about how best to use simulation-based education, assuming we know it works. And so tomorrow in day 2, you will be applying aspects of implementation science to SBE. And what I've done is I've chosen a particular sort of logic model for everybody to work through tomorrow. Next slide. All right, so this looks like a lot. I get it. Looks like a lot, but it's not. So on the left-hand side here, we have determinants. And if you want a synonym for determinants, it's just the barriers and the facilitators to implementing a particular practice. And you see CFER abbreviated right there next to the determinants, because these 5 blocks underneath the determinants come from the CFER model that we've already talked about. And you can see all 5 of them listed here: intervention characteristics, inner setting, outer setting, characteristics of individuals, and the implementation process. Okay, so what you'll be doing is, through a set of guided questions, you'll be determining some determinants. Aren't I cute? Okay, you'll be looking for some questions you would want to answer about implementation that falls into one or more of these domains. You by no means have to select every domain. You by no means have to select every question provided to you that's in a particular domain, right? It's like, okay, if I was to teach this in my class tomorrow, or if I was to ask my faculty to adopt simulation-based education, which of these questions would I be able to answer or be able to collect data on? The next part of the model, so just over in the next one, so click next for me, Hannah, is implementation strategy. So if you remember all the way back to my second slide about implementation science, this is how do we get people to do the thing? And there are a lot of ways that you can strategize around implementation. Most of them are planning. Yes, you have to plan your implementation. Educating. So do you need to train facilitators? Do you need to educate students about how simulation-based education differs from what they're used to? Whether any restructuring needs to occur, whether you need financial resources for implementing SBE, and those are just a couple of options. So those are, what do we do? How do we get people to do the thing? In the next box, we have mechanisms. And I'm going to tell you tomorrow, please leave this blank. So mechanisms are the process through which the implementation strategy operates to affect your desired outcomes. These are really few and far in between in the implementation science literature, mostly because they require data to be reported from the other variables in the logic model before you can make guesses about how the implementation strategies actually work. So we're going to just skip right over this box tomorrow because I don't think we have what the information that we need to make educated hypotheses about how the strategies are working. And if you want an example of a mechanism, if my implementation strategy is education and I want to understand faculty self-efficacy in using SBE, a potential mechanism is that education about SPE improves faculty self-efficacy, which leads to increased measures of acceptability. That's an example of a mechanism. And then the last stage in the logic model are our outcomes. And there are 3 boxes here because there are 3 different kinds of outcomes we're interested in, which I showed you again earlier in the presentation. It's just that now it's vertical instead of horizontal. So the implementation outcomes, those are things like acceptability, appropriateness, feasibility. We also want to think about what are the student outcomes, knowledge, critical thinking, problem solving. And we also want to think about what are we hoping the end result will be for the patients that our students are working with. So that might be efficiency of care, or it might be empathy, which I heard come up, or it might be increased patient-centeredness. We are going to do this. We're going to, basically our goal tomorrow in our small group discussions is to fill in this chart, except for the mechanisms section. And the way that you will do that is I will provide all the possible options for filling in this chart, and you will select just some of them. So just the tippy top of your toenail, not even the toe, just the toenail, into implementation tomorrow, so that you can get a sense of what that looks like, what questions you're interested in, what questions you may already have data for to like get the answer for. And also it's going to be a way to sort of assess where you're at with implementation science. So do you feel like you get it, or do you feel like you'd really like some more information from someone about it? So any questions about what we're going to be doing tomorrow when we get together? okay, this is just like my students. Like, I know you have questions and I know you're not asking them. And then we're going to come together tomorrow and you're gonna be like, I don't remember what we're doing. It's okay. I'll explain it tomorrow. So, yeah.
It's not a question, more of a comment. You know, a lot of what you're referring to requires a systematic assessment system that I think, you know, from a student learning component is difficult for a lot of universities. That we do a lot of siloed assessment, but putting together some type of comprehensive assessment system is a challenge. And from my perspective, that takes a change management strategy, right? So you start in with awareness of why we need it, desire that you're building in the faculty to do it, and then giving them the skills of how to do it, and then reinforcing that down the road. So we have a team that we had a faculty-driven assessment team that we started that change management process related to implementation science.
Oh, great.
And then we had a data day. So we brought all the faculty together with all the data related to all the things you're talking about and walk through, okay, you've got this piece of data. How can we refine it? What do we need to do to systematize that? How do we use that for understanding the implementation process? And it's not perfect. It's an ongoing and evolution that has to occur. And I hope you'll talk about that change management process and the overlap between the implementation science and the look at assessment data, because I think otherwise you get siloed professors who understand implementation science and they're doing it in their classroom, but it's not changing our outcomes of an institution overall.
Thank you very much. That sounds incredible. A data day makes my heart happy. Yeah, so I'll think about that for tomorrow. Thank you.
But one question for tomorrow that's come up. Should we have?
Can you lean forward and talk?
Yeah, sorry. Should we have one specific research article to review for the to fill out the logic model, or have you presented us with the data that we need to do the logic model, or is there something else that you're having us do? Thanks.
That's a great question. So Patricia asked whether or not there's some research paper or research outcomes that you need to prepare for tomorrow. So basically I've done that work for you, right? I've already collected and presented the evidence that is the basis of this evidence-based practice, which is simulation-based education. And the idea tomorrow then is that you would be thinking about what types of implementation factors you're interested or might be interested in studying for that practice. So all you need for tomorrow is an understanding of what simulation-based education is and how you might like to see that studied in your own local context. And then of course you'll be working in small groups tomorrow. So what I'm hoping is you'll have lots of great discussions about potential ways you might measure those implementation related variables, or you might get lucky and be in Carl's group where he can tell you about this fantastic thing they've done at his institution. So you don't need any of the research articles, you just need to be familiar with simulation-based education.
Okay, thanks.
Yeah.
Rachel, there's a question that says, per the IRLM, were there clear definitions for inner setting and outer setting?
So tomorrow there will be specific questions focused on inner and outer setting that I think will help clarify the difference between those two things for you. And if not, or if you'd like to brush up on that a little bit before tomorrow, you can just do like a Google image search for the CFR, and it'll bring up a lot of really helpful diagrams for each of the domains. And I see Nazreen has her hand up.
Thank you. Thanks for that, Rachel. I can understand the question about whether there's a particular example that will be provided for everyone to go through. And it may not be a research article, but is there a particular clinical practice, given that everyone's coming from different professions and might be in mixed groups? There, in the first few minutes, it might be about, are we talking about a particular simulation of a dental practice, or is it a particular simulation of hypertension screening, for example? So is there a particular clinical practice that we want to be focusing on, that we would think about the environment for simulation for that? Or is it all up in the air?
Thank you, Nazreen. That's a great question. So this might be my unfamiliarity with health professions education, but I was envisioning each person choosing for themselves what SBE looks like in their context. And even if that's the case, that you would have, you know, a simulation of like cardiac arrest in one situation and something dental related in the other, there should still be commonalities in the types of questions you want to answer about implementing those simulations. But there might also be differences in terms of resources or processes that would be different depending on the type of simulation. And in that case, your section of the logic model might just look a little bit different than somebody else in your group.
So everybody's going to have their own.
Yeah, you'll just imagine your own. The reason I think that is because when I think about other types of evidence-based practices, so let's go with the flipped classroom model. The way I implement a flipped classroom might be different than how my colleague implements a flipped classroom, but we both still want to know, for example, how do our students feel about our iteration of the flipped classroom? And I also want to understand, with this particular iteration of a flipped classroom, how burdensome is it for faculty? And the benefit of doing that is that now we have multiple sets of data from different areas so that somebody else can make an informed choice about how they implement a flipped classroom model based on which of these is most similar to their own personal context, rather than just having one piece of information about implementation. But if what I'm hearing is that that's not a good fit, then we can select one type of simulation at the beginning of the session tomorrow. Yeah, Carl.
I just think your idea of doing it with the logic model is fantastic, and to do it separate to me makes more sense, because all the participants then walk away with a model that they can use. So I think that's an important piece. It might just be a little struggle to figure out how to do that in a group, but each person walking away with their own, you can take that and apply it.
Okay, great, thank you. That's how I had imagined it.
So we can send that out to all the participants that haven't received it as of yet. I believe just the 4 members received it. So we'll get that out to everybody.
Great, thank you. Okay, I think that's it for us today. Thank you all so much.
Thank you.
And I look forward to seeing you tomorrow.
Thank you, Gail, Natalie, and